everyone, and welcome to the Greater Lawn Health Hub at West 55th Street. I'm Dr. Alex Sloboda. I'm a medical director at the Chicago Department of Public Health, and I'm very excited about this important event and discussion this evening with some wonderful guests who I will soon introduce. There's a couple statistics we want to touch on before we get started about the importance of this topic in terms of Black men's health and heart health as well. First, between 20 to 60% of all heart attacks are what we call silent, meaning they happen without the dramatic chest clutching symptoms we see in the movies that are often associated with having a heart attack. But it doesn't always happen that way. It's important for people to know. Even more concerning, Black men face disproportionately higher rates of cardiovascular disease and are more likely to experience these silent heart attacks at younger ages as well. But these numbers aren't just statistics. They represent our fathers, our brothers, our sons, our partners, and our friends in the community. They represent lives that can be saved through more knowledge, prevention, and community action, and that's why we're here today. At CDPH, we believe that health equity starts with honest conversations in trusted spaces such as these. So tonight isn't just about medical facts, it's about empowering each of you with practical tools you can use tomorrow. It's about breaking down barriers that prevent Black men from seeking care, and it's about building a community where looking after our health isn't just seen as a weakness, but as a strength. And so like I said, I'm Dr. Alex Sloboda. I'm a medical director at the Chicago Department of Public Health, but I'm also an emergency medicine doctor as well. So I've also witnessed people experiencing some of the toughest moments in their lives when they have heart attacks or have emergencies from heart disease, and have taken care of patients experiencing this as well. So. But that's why I'm glad we're here today with some of our amazing expert guests to talk about what we can all do to help prevent heart disease and heart attacks in Black men in Chicago. All right, so I'll kind of go through our panelists, our experts, as well as a special guest of ours, and then we'll get started with the discussion. So to my left, I have Dr. Marlon Everett. Dr. Everett earned his undergraduate degree from Howard University and his medical degree from the Chicago Medical School. Dr. Everett's philosophy and life mission is one of service, and he sees the heart as a powerful organ that directs all aspects of life. He is dedicated to health equity and is an active member of the Association of Black Cardiologists and has coordinated the organization's Spirit of the Heart program, which is an outreach effort designed to facilitate discussion amongst health advocacy groups in Chicago, as well as area churches and barbershops. Dr. Everett has frequently participated in medical correspondence on television for Fox Chicago News and blackdoctor.org, as well as on the radio for Project Brotherhood Radio. Next to Dr. Everett is Dr. Daniel Luger. Dr. Luger received his medical degree from Rush Medical College. He then completed his internal medicine residency and cardiology fellowship at Mount Sinai in New York City. As a non-invasive cardiologist, his primary areas of focus are echocardiography, advanced lipidology, and primary prevention. So he can talk about what those complicated words mean to the rest of us. Dr. Luger launched the Great Rush Center for Prevention of Cardiovascular Disease, and this is an interdisciplinary clinic dedicated to treating cardiovascular risk factors such as hypertension, hyperlipidemia, obesity, and sedentary behavior lifestyles. So we'll talk more about that tonight as well. The center, through individualized lifestyle interventions and medical therapy, works to address these issues with patients individually. His interest in addressing healthcare disparities and founded the Cardiometabolic Health Initiative, a mobile clinic that provides cardiovascular preventative service to food insecure populations on the west side of Chicago. To his left is Dr. Rutland. Next to Dr. Luger is Kevin Monroe, who is a special guest tonight, and we'll get to hear more from him. But he's gracious enough to share his own experience, personal experience recently with a heart attack. And on the end there, last but not least, is Dr. Louis Rutland. Dr. Rutland received his Doctor of Dental Surgery degree from Meharry Medical College, graduating at the top of his class with high honors. Patients come from all over Chicago and out of state to see Dr. Rutland for all their dental needs. Dr. Rutland is a fellow in both the International Congress of Oral Implantologists and the American Academy of Implant Prosthetics. As a black male dentist, Dr. Rutland is interested in the connection between oral health and heart health, which will be an important discussion tonight and something that's probably often overlooked. As gum disease can trigger cardiovascular problems and increase risk of having a heart attack, and childhood oral infections can contribute to clogged arteries in adults. Treatment of gum disease has also been linked to a decrease in blood pressure, and that gum disease and heart disease, particularly coronary heart disease, which we'll talk about this evening, often go hand in hand. So those are all our amazing guests tonight that you'll get to hear from. So we'll get the panel started. I think the first question, just so everybody has a better understanding, I'll give this to one of our doctor guests. Can someone explain in layman's terms what a heart attack actually is and why might someone experience one? Anybody interested in one of our cardiologists?
You're a cardiologist. So the question is, what is it, a heart attack?
Just what is a heart attack in layman's terms for people to understand?
So there's a lot of misnomers out there, and there's layman's terms, but essentially a heart attack means that you're losing heart muscle. The heart's a muscle, you don't get it back, so our objective is to try and prevent you from losing any of that muscle. Muscle does not regenerate itself. So what I do in the middle of the night and what Dr. Luger does to try and prevent people to have these heart attacks, or to prevent losing this heart muscle, whether that is a blocked artery that we talk about, and we'll talk about cardiovascular disease, as well as a lot of the layman's, a lot of people will talk about heart attacks when they faint or they have a heart rhythm problem, and they may be considered a heart attack. That's a different type of heart attack because you don't necessarily lose muscle, but that could be an electrical issue, and we call that sudden cardiac death. So essentially, you do die, unfortunately, from it. So in theory, it's like a heart attack, but I think for this conversation, and especially from a preventive standpoint, we're going to focus more on protecting the heart muscle and preventing you from losing the heart muscle. I think that's it.
Yeah, thank you.
Anything else?
You nailed it. I would say just part of the equation is the loss of heart muscle is often from a clogged artery. And the process of having an artery clogged, that starts when you're in your 20s. So this process of what we call atherosclerosis, this is gunk buildup in the pipes. That is a very slow moving disease. It's a very unique disease state in that you can live for 50 years and never feel it, never have any manifestations of it. And it's also a systemic condition, meaning if there's gunk in the pipes in the heart, then there's gunk in the pipes in the brain, in the neck, in the kidney. So we treat it as a full body condition. And one of the statistics I would have added to the beginning was that 80% of cardiovascular disease is preventable. So if we identify early signs, if we identify risk factors, intervene early, most of this can be prevented. So that's why it's, my interest in health equity and in prevention comes from the fact that we can change a lot of this. We just have to mobilize, we have to educate. And most of my visits when I'm with my patients is just the education piece, so that people can buy into taking treatment for things that they don't feel right now. You don't feel high blood pressure, you don't feel high cholesterol, but you have to understand the mechanism that drives heart attacks and intervene early.
Yeah, no, thank you for that. So that's helpful. We'll definitely get into the education parts this evening as well. Anything else or other panelists want to add about heart attacks or what heart attacks mean? Okay. And then I think there's a term that is getting more attention, specifically silent heart attacks. Does anybody want to explain what exactly is meant by a silent heart attack and what's silent about it, and what should people be aware about this?
I guess that's a layman's term, so I'm going to try to guess what that is referring to.
Usually not having the
crushing, the typical symptoms. Yeah. So I mean, this is if we're talking focused on men here. Usually, it's the men that present with the crushing chest pain, the sweating, like you're having a heart attack. You walk into the emergency room, they know you're having a heart attack before they put an EKG on you. But a lot of people can present atypically, meaning they don't have the classic crushing chest pain. They can have exertional intolerance. So, you're walking up a flight of stairs a couple days ago and now you're huffing and puffing after a couple steps, or shortness of breath, or even people can confuse indigestion for like reflux or something going up the stomach, when it's actually the heart. One of the arteries of the heart sits right on top of the stomach, so you can get kind of stomach discomfort that's actually is a heart attack. But also there's the full-blown heart attack where a blood vessel is completely clogged up. There's also kind of disruption in the artery that doesn't prevent total blood flow, but it's a form of a heart attack. So it's potentially a precursor to worse things happening. So it's kind of like on the education side of things, it's teaching people to understand the early signs or the subtle signs that at least should prompt you to seek further care in those scenarios. I think that should hopefully covers that.
Yeah, and I add to that, and I think that exactly right. I think it is more of a layman's term, but I think it's important to understand that every heart attack doesn't kill you, but every heart attack can kill you, and so that's why you will have some people. We see every day in hospitals. We see someone has a heart attack and they live through it. They get medicines, they get treated. We do a lot of, for lack of better words, Band-Aid work, putting stents in and so forth. But I think that the meat of it is trying to really address the reason why they had that. What Dr. Luger talked about was the whole 50 years of developing all these plaque buildup and so forth, this systemic inflammatory process that occurs for many, many years. We really need to attack that. What we're doing is just trying to we're really doing Band-Aids, and I'll say it like that again, because we're just patching you up and sending you back out. And if you don't do something different, you're probably going to come back the same way. So I think it's important for us to understand. But when we talk about silent heart attacks, I think people talk about the not feeling the heart attack so much. Clearly, as you mentioned, in men, it's usually more apparent. Women are much more subtle signs. It can be shortness of breath. I can tell you one of the biggest masqueraders, and he touched on it, is this indigestion type pain. One day I was at my house, and I lived on the south side, and one of my neighbors came to my door, and he was kind of a cantankerous, kind of mean guy in the neighborhood, but he liked me because I was a neighborhood doctor or whatever. And he knocked on my door about 10 o'clock at night, and he came to my door and said, he had an empty box of Prilosec, and he'd taken all of the Prilosec within 2 hours or an hour. And I said, well, it's probably not, Prilosec is for heartburn. So it's probably not heartburn. And after convincing him he wouldn't let me call the ambulance, I actually drove him over to University of Chicago, and he was actually having a heart attack. So it just goes to show you that chest discomfort, that indigestion type pain, I think is one of the biggest masqueraders out there. Yeah. And we have to be those. I'm sure you see that in the emergency room as well. Yeah.
And then, Mr. Monroe, is there anything you want to add about your experience?
No, I think I was the silent one. So I went to the emergency room, and I was having pneumonia, didn't even know it, but I was having chest pains. And the question they asked me was I on steroids, and they gave me some muscle relaxant and sent me home. And I went to a hospital in Houston, and they said, okay, this guy is having a heart attack, continuation, I guess, so they put some stents in. But I'm the silent type. I wasn't having that massive chest pain. I kept saying, look, my chest is kind of feeling funny. And they did some testing, so we got to put some stents in.
Good. Thank you for sharing. Yeah, the thing about the heart and these heart attacks, it can be a different experience for everybody, so it's important to be aware of the different symptoms. We've talked about, been touching on some other health conditions that relate to the heart and heart disease. Often there's a discussion about high blood pressure, high cholesterol, diabetes. Does anybody want to kind of touch on how those relate to heart disease or how they contribute to heart disease and eventually having a heart attack?
So I'm not a physician, but can I answer this?
Yeah.
So my physician kept telling me, Kevin, you need to take this cholesterol medicine. And I'm like, no, I'm not. I think like 12% body fat, muscular. I'm like, I don't need it. I ain't need it. He said, you're going to be a pretty corpse. That's what you're going to be, a pretty corpse. And we talked recently, and he told me it was my bad cholesterol was 355.
That's not good.
So I'm on my medication now. I'm at 55. So my one advice to people is to take the medication. A lot of people say, hey, look, I'm going to take the medication because of the side effects, and people want to become Google doctors. I mean, these are real physicians, are very impressive people. People start going online and said, I'm not taking medication, all these side effects. I say, look, man, but for the grace of God, I should be dead. 355, bad cholesterol was, my doctor's one of the highest he's ever seen in his life. Yeah. So take your medicine.
Thank you for that important message. Anything you want to add about the other?
Yeah, 355 is high, very high, even for a lipidologist, which means I'm a cholesterol expert, and that's pretty intense. But I don't typically predict my patients to be corpses and try to
positive.
aspiration. I mean, so what I'm about to say is what I've said for my 10 patients that I saw in clinic today, trying to educate them on like the disease process and explaining how asymptomatic conditions lead to generation of disease. And so basically it all comes down to maintaining the integrity of the artery lining. And again, this applies to strokes and kidney disease. It's anything that puts stress on the artery wall allows for cholesterol to then deposit into the wall. And when the cholesterol starts building up in the wall, your body starts initiating an inflammatory response. And again, this is a slow-moving process, but the key is to address the cholesterol and lower it, and also address any risk factor that contributes to damaging the artery wall. So that's lowering the blood pressure, which puts this kind of shear stress on the artery wall. It's treating any inflammatory conditions that leads to that spiral of inflammation. It's not smoking, so that those toxins don't damage the artery wall. And similarly with sugars, you get glycosylation or glucose buildup on the artery wall, and that leads to cholesterol penetrating the artery wall. And if you intervene on these conditions, you really do prevent the plaque from depositing, and you prevent it goes from like a little foamy kind of plaque develop into full-blown either narrowing of the artery or a plaque that then ruptures and causes a heart attack. So all these medications reduce the risk of plaque developing in the first place and will stabilize whatever plaque is there.
Yeah, as well as the lifestyle modifications that he's talking about as well. That those arteries they don't want to be perturbed. They don't want to be damaged at all. So, one thing, high levels of sugar, that's diabetes, right? That circulating sugar can cause inflammation. Smoking causes inflammation, and I think this is a perfect segment for Dr. Rutland on the end to talk about how, just the chronic inflammation that you have that can happen in the mouth that can lead to this systemic process. It's all one. You mentioned it. It's all just one system. I think of it like a house. A house has pipes that goes all around it, right? And these pipes can go in different rooms. You can have a pipe blocked in one of your bathrooms. The rest of the bathrooms are fine, but the one bathroom has a clogged pipe, and that bathroom doesn't work. It's the same with the body. You have legs, you have kidney arteries, you have brain arteries, you have heart arteries, all one system. and all of them are they can be affected by high blood pressure, by diabetes, by high cholesterol values. They can be affected by smoking. They can be affected by sugar. You know, we used to, in our field, we used to be really, really obsessed with cholesterol. And I think we started a little bit now, but you know, I think over the last 15 years, I think many of us have really started to understand that a lot of the issues are really coming from inflammation. And sugar is probably one of the biggest inflammatory agents out there, you know. So that's being said, but I'll let Dr. Rutland talk about this chronic inflammation that can happen if it's in your mouth. That means you can be inflamed in the rest of your body.
And that's something that a lot of people really just overlook, how it got there, the origins. The mouth is typically, and I know this sounds like something a dentist would say, the mouth is kind of like the gateway to the body. A lot of times what happens is the word itis, inflammation, periodontitis, inflammation of the gums. You have these inflamed, the name of the game in dentistry is to reduce inflammation. It seems like in learning, it's the same thing in cardiology as well. When you have inflamed gums, you have bleeding gums. That's a direct pathway for these toxins to get into your bloodstream. So usually most people, it's kind of one of those things that, yeah, I kind of need my teeth cleaned, but it's just one big tube. It's just one big circulatory system. So what happens is a lot of times, if anyone in here has ever had a major surgery, one of the first things they have you to do is to get dental clearance. And you ask yourself, why would I need dental clearance to get a hip, or to get a knee, or to get a heart surgery or something like that? Because those surgeons don't want any plaque, bacteria, inflammation, anything extra that's going to mess with their surgery, they do not want it. So they want the dentist to take a look at it, make sure the level of inflammation in your mouth is down, the level of caries is down, you don't have any bleeding gums, because they want to make sure their surgery has a better chance of succeeding. So as a dentist, I definitely don't want to step over into what the cardiologist is talking about, but just from a dental point of view, you can really help yourself by reducing the plaque, the bacteria, the inflammation in your mouth, because there's a lot of correlation studies that show that there's like some serious links between gum disease and heart disease. There's no direct correlations at this point, but there's a lot of them that suggest the majority of people that have heart disease have some form of gum disease.
Yeah, I think that's important to know, because your heart is pumping blood going everywhere to your body, so your entire body is connected to your heart. Mm-hmm. So yeah, thank you for the useful information.
Can I add one
yeah,
more risk factor that's now emerging is treatment of obesity as it relates to cardiovascular disease. So obviously obesity is oftentimes the root cause of some of these other risk factors like high blood pressure, high cholesterol. But we're now, instead of just kind of mopping the floor while the faucet's still running, we're trying to go upstream and actually target obesity and adipose tissue, fat tissue, as a direct cause of cardiovascular disease. So I don't know if you guys watch the commercials for Ozempic, sorry, I don't think I hit it right. But there's Ozempic, Wegovy, all these medications. Now there's actual clinical trials that show that these medications are a cardiovascular drug. They reduce heart attacks and strokes. And so it's not just about Kim Kardashian having a tight waistline. It's about actually protecting your heart and preventing cardiovascular disease. So that's a huge emerging field, and I think we're going to see a lot more about the gut heart connection, all these gut hormones, and how it relates to inflammation, obesity, and cardiovascular disease.
I think he's exactly right, and I think that obesity is an independent risk factor. About 20 years ago, I remember there was a study looking at the correlation of some sort of gastric surgery, whether it's bypass or balloon or anything. The bottom line is people got their weight down, some sort of weight, whatever way, hook or crook. That led to improved cardiovascular health or lower cardiovascular events just by lowering the weight, no matter what way you got there. So that just, at that time, it was always kind of a correlation, but I do agree that I think it's more of an independent risk factor that we need to address.
Can I interject something real quick? So you mentioned lifestyle, And I'll say for me, I have a strict lifestyle. I work out 2 hours a day. I eat the same meal every day, high protein, gut healthy food. And I forgot to ask questions about hereditary. My mother passed of a heart attack. My grandmother passed of a heart attack. My cousins on my mother's side all have, but a lot of them have heart conditions. And I realized that you can't outwork genetics. And again, I will emphasize, take your medicine. Because if it's in your genes, you just got to take your medicine. There's nothing you can do. And the fact that I was in such good shape that allowed me to survive. I took a plane from Chicago to Houston having heart problems. And if I had not been in the shape I was in, I might not have survived. You probably would have survived. And I was telling the doctor that when I had the open heart surgery, they minimally invasive. I was only in the hospital for 3 days after having but it was open heart surgery for 3 days. But it was because of the lifestyle. So I had the lifestyle, but I also had the bad genetics, and that's just what I was born with. Take the medicine.
I just want to, as a mother of 2 young men, 2 black young men, a wife, and just surrounded by, men who have high blood pressure and just asking a lot of questions. So what I've heard you say today is there are so many different factors to consider. I've heard you talk about, inflammation in the gums. I've heard you talk about, just having the genes and having something that runs in your family and just paying attention. And if you have to take medication, take the medication. I've heard you talk about, obesity and the role that, being fat around your waist can add to the risk of having high blood pressure or heart disease. And even the food we eat, glucose and all the inflammatory components of all of that and not working out enough. And so if I were in the audience or listening in as a Chicagoans and how do I know which of these things are my problem? And how do I know? Because people say to me sometimes, well, I'm not obese. It's not my problem. Or I don't have gum disease. So when we say risk factors, can you break it down a little to the average person? And say, we're not saying if you have this, then this is gonna happen. There might be little bits of this and that. Sometimes it's 1 or 2, sometimes it's even 3 of these factors. Sometimes it's just the one. What we're saying is that risk can vary, it can be multiple, it can be 1 or 2. Is that correct? Is that a fair summary of some of the things that you're describing?
Yeah, and we actually have risk calculators. So we plug in these various risks into a calculator and calculate your 10-year risk of having a heart attack based on your age, your smoking status, your diabetes status, your blood pressure, your cholesterol, and that is somewhat predictive of whether you're going to have a heart attack or a stroke in the next 10 years. But what we're moving towards now is actually doing more imaging, non-invasive, low radiation imaging to actually see what your coronary arteries look like at a younger age. So maybe you have sleep apnea, obesity, but everything else looks fine. We don't know, it's hard to predict on this calculator, what does that mean your risk is? So now we go and actually basically do a mammogram for your heart arteries, a low dose of radiation, and it tells us, do you have the earliest signs of plaque formation? Is there gunk buildup, the early signs of gunk buildup? And that oftentimes leads us down the road of whether we need to treat it or whether we just continue with lifestyle modifications and kind of check in every couple of years.
Yeah, I agree. And I like what he's mentioning. I'm an interventional cardiologist, so I put stents in after the fact that they have, but I really believe in preventing it. And that's what you just mentioned, but I think that identification is important because I think that, and I could be wrong, but if you had seen that you had plaque in those arteries by a low dose calcium test that shows some calcium in your heart arteries, doesn't say your arteries are blocked, but it does show calcium, that might have led you to say, you know what, maybe I do need to take my cholesterol medicine now. And that's why I think it's really important. And just about every hospital offers that now. And it's, usually, unfortunately, I don't think insurance is paid for it, but I'm actually working with legislation here in the state trying to get it covered. It's $49 that you have to pay for it. But I think those type of tests, Look, there's no one. There's always someone who smokes cigarettes till they're 90 years old and don't have a heart attack. There's always somebody who has a cholesterol number that doesn't have a heart attack. You can never predict it. But there are people who have spent their career in our field trying to predict who it is, and you will never be able to predict it. What we do is we add all these risk factors up and come up with a percentage to say that you might. It's never going to be a you will. So that's why I think it's important to understand that there's a number of risk factors, and there are always emerging risk factors that we're always coming up with, that we're seeing, because we just don't know it. I've been practicing almost 25 years, 20-something years now, and I tell you, there are risk factors that were not identified back when I was training that are now here. So I think it's just important to understand that you're just trying to figure out for yourself as a regular Chicagoan, look, do I have this, do I have that, do I have this? Will I have a heart attack? I don't know, but I know I want to reduce it. And the only thing you can't reduce is your family history.
Right.
Really, that's really the only thing you can. But just about everything else, it's modifiable. There are lifestyle modifications. So do your best. That's exercise. That's don't smoke. That's keep your blood pressure down. If you can't keep it down, take medicines for it. Keep your cholesterol down. If you can't, take cholesterol medicines. Keep your sugar down. Obesity does lead to diabetes and higher blood sugar levels. So you keep your weight down potentially. I have a brother who lost 40 pounds and had high blood sugars, no longer had high blood sugars after that. So it can happen.
Thank you. And then we do have a new guest joining us that we have not introduced yet. We have our Chicago Health Commissioner, Dr. E. Gay, that snuck in, and we're glad to have. Anything else you want to add? I think we might shift a little bit to the public health and community perspective and some social factors, but.
I just want to say thank you for joining us in this conversation. As the city's doctor, I have the responsibility of safeguarding the health of almost 3 million people. So, and I became really worried because heart disease is the #1 reason why people are not living their full lives in Chicago. It's the #1 cause of premature mortality in Chicago. And then we started to unpack the numbers, and we saw that it is, men are not just doing so well. We're seeing numbers go down for women, but for men, the numbers have just stayed consistent for the last 15 years. So we wanted to unpack that a little for folks, and what do men need to know? How can we engage with men and help build this relationship with the primary care provider and cardiologist, the places that people need to go to figure out, am I at risk? And if I'm at risk, what can I do? So I just want to say thank you for coming, and especially for Kevin coming to share your story. I think it just makes it real for everyone to know that you can look like you, be fit, and things may still be wrong and you don't know it. I can share my own story. I have, a 23-year-old. We started noticing the high blood pressure going up at age 15. His family, the father, the grandfather, there's some family history, is 120 pounds at that time. The cardiologist and eventually at 21, he had to start medication because he's 160, 120, So some of these things you just need to keep a close eye if you have a family history, and just make sure you have a relationship, with a doctor you can trust. And if they tell you something is wrong, get a second opinion if you have to, but if something is wrong, you just want people to address it. Because, so many members of the family had died, at 40s, in their 40s, and, the problem started from when they were 16 or 15 and they didn't know it. So it is personal to me that people hear this message and they take advantage of the expertise that we have in Chicago to stay healthy and build relationship with the provider community.
Kind of going into that, we have all these teams in public health working, or we have epidemiologists that are looking at this data, who's being most impacted, who's highest risk in the city of Chicago. Like you said, we know Black men are significantly impacted by cardiovascular disease, can be at a higher risk. And I know all of you do a lot of work in the community, doing outreach, community work. So what are some of, and the social and other factors that may lead to kind of these racial and gender disparities that we're experiencing in the city of Chicago?
I can tell you, I am a proponent of less inflammation in food. And so, one thing I'm sure many people have heard, but you understand that there's a huge disparity of life expectancy from one side of the city to the other. And a lot of that has to do with these, what we call food deserts. And I'm sure many people have heard that, but if you don't understand what that means, is essentially there's not a good place near your home that you can have access to be able to get good quality food. It's prevalent in the hospital I work, in the community that I work in now. I see it all the time. I think that's one of the issues. The food desert aspect of it is what contributes to that. So if there are ways that we can improve that, I think that would be one way. What do I mean by diet? I do believe the closest that you can get, and I get some people arguing with me all the time about this, because I think that it's a difficult thing to do, but the closest you can get to a plant-based diet, I think the better. There are some populations in the world that do eat plant-based diet and they do have heart disease, but I have not seen that in black men and women. I have not seen a vegan in my office or on my table yet. Or my table, when I mean my cath lab table. Not saying it can't happen, but I just have not seen it yet. So until I do, I'm going to say that, and I'm sure there will be, because there will be some vegans that have cholesterol at 355 potentially, because it's all genetic based. But in general, though, I think that's kind of the way that we need to move towards, as close as you can to a plant-based diet.
Anything else?
Yeah, in the communities that I serve on the west side of Chicago, we do social determinants of health screening, so asking about, basic stuff like access to food, transportation, safety in your neighborhood. There are all these social factors that contribute, not just practically like getting to a doctor or being safe in your neighborhood to go exercise, but also like the real physiologic impact of psychosocial stress. That's another risk factor, is mental health, that it works in both two directions. One is the direct consequence to your cardiovascular system. So people that are under chronic stress have higher levels of generalized inflammation. We can actually measure their level of inflammation in their blood, and it correlates with the levels of stress that they're experiencing. And as we've talked about, inflammation drives disease of your arteries. People that are depressed, isolated, lonely, don't feel safe, they also have their platelets get stickier. There's all this physiology that contributes to an increased risk of coronary disease. And then the other part is that people that are, disillusioned or, disengaged are more likely to drink, smoke, and have these other and less likely to adhere to a healthy diet. I mean, if you don't feel safe, if you're worried about the safety of your kids, for example, you're not going to care about taking a blood pressure pill. You're focused on something else, and then you're engaging in behaviors to soothe yourself. So there's a lot. It's a highly complex, and but the work that we're trying to do is to dive into the social aspect of it and see what we can modify in that piece to drive down cardiovascular disease.
Yeah, I love exactly what you're saying. That social determinants of health, I think, are everything. And I think one of the ones that is there is monetary. If you don't have a job, you're worried about how you're going to pay your bills, how you're going to feed your family. That's stress. And then to bring it down to, and then if the food is too expensive because you can't eat, it's much easier to eat a three-piece fried chicken for 99 cents or $1.99 versus vegetables. It's just, it's unfortunate. And so monetary, we have to ensure that people have jobs, that people can make living wages, that can actually live in a city like Chicago and live anywhere. And then also, we bring, I don't know this for sure, but I know that when I go to the dentist, I have to pay. I have dental insurance, but sometimes there's a little bit more. Maybe, I don't know if we're not, if the public, if from a public health standpoint, we're not being able to support people to be able to have preventative dental care, which then also leads to more inflammation. What do you think, Dr. Lovett?
Well, I don't think that we as a society have really invested in dental care. I graduated dental school in 1994, and the annual maximum that insurance companies will pay was right around $1,000 a year for dentistry. 31 years of practicing, it's still $1,000 per year for your annual maximum. So typically what I see that hits the hardest is the gingivitis and periodontitis. Those are two different forms of gum disease. Maybe around 2/3 of people in the United States have some form of gum disease, no matter how mild it may be, but gingivitis, inflammation of the gingiva, periodontitis, inflammation of the periodontium. All that is the inflammation that I see, and one of the biggest things I see is the smoking and the old school, the dipping snuff and things like that, but now you have vaping, you have women smoking cigars, it's like the whole paradigm is just really shifted. So the majority of teeth that I take out you would think would be from cavities, but the majority of teeth I take out are for gum disease. And it erodes the gums, it erodes the bones, so if it's doing that in the mouth, I can almost imagine what it's doing by the time you guys see it.
My gums hurt just hearing you.
My heart hurts just hearing
Yeah, I mean, I know a lot of you work with organizations that are in the community trying to address these issues. We've talked about, like, honestly, like, being a vegan, being a vegetarian, eating healthy is just more expensive than eating fast food. It's just how our society is right now, unfortunately. And we've talked a lot about exercise, but there are work and organizations going on in the community trying to address these barriers, address these social determinants of health. Can some of you talk about the different orgs you even just know about or worked with that are out trying to overcome these social determinants of health barriers, getting people access to healthy food, getting people access to exercise and gyms and things like that?
Let me start, because that's our territory.
Yeah,
We're the ones who have the responsibility of making sure people have food. I'll start with the Parks District and the work that they do. I just heard a wonderful presentation today from the CEO, and that, do you know that in Chicago, everyone lives within 10 minutes walk of a park, of a green space, of a space for exercise or recreation. So that is an asset that we have. Every single of our 77 community areas is within a walking distance of a park, of a recreational fitness center kind of facility. I think that is very important for people to know, and this is no cost to Chicagoans. So in terms of green space, swimming pools, open spaces, safe spaces for exercise, we know many people live in communities where there are no bike lanes and there are no safe spaces for exercises. So that's one of the partnerships that we're exploring. But the food component is the part that I want to explore. So food deserts, I mean, there are community areas in Chicago where there are no grocery stores. We have done the mapping, we know where they are. And so what do? So we know that during school periods, you know, kids get to have some meals at school, and sometimes they're able to take some things home. And during summer, we know Parks District also, as the school meals are ramping down, meals are being set up at the parks also to ensure that kids can have food. But what happens to the adults and the parents is the question that I've been asking. So we've been working with some organizations, the Greater Chicago Food Depository, for instance, and help them identify where the deserts are. These are opportunities for people to have a food box, or go to a food pantry and at least be able to get some food. And then people say, oh, but there's no fresh produce there. So how can we ensure that these food pantries have some fresh produce and some fruits and vegetables as part of the option? Said, oh, it doesn't keep, well, maybe that's where we can come in as the city and help facilitate. So we have food markets and farmers markets where, during summer, these farmers markets are hosted, but we don't always sell everything. So what about food rescue, and how can we ensure that the food that's left over, we can ensure they get to the communities where there are food deserts? So we piloted some of that last year with the Department of Cultural Affairs, making sure that, food can be rescued and then it can go to communities. And this is good food, not just, farmers market, fresh produce, go into communities that need them. And we know that we have some partnership, Londale Christian Center, they have the Urban Farms Initiative, there's Food as Medicine. So when people are screened and they have food insecurity and they need the additional, support for fresh produce, they're referring people to some of those gardens where they can get a week's worth of food and vegetables. And, partners like Build on the west side where they have gardens and people can come and get a week's supply of fruits and vegetables and things like that. So there are a number of options now that we're exploring. One thing is to help people know where to find this information. 211 is the place where people can go put in their zip code and say what is around me, where are the options. If that doesn't work, we have our Department of Family and Social Services. For seniors, they have food boxes. They have additional support for food and even home delivery for food. We have those who are on Medicaid now can get support for food and food delivered to them at home. If you're a child, you can get food at school or get food in the park. So we just want people to know that there are options. We know that our communities need additional help, but I think a big gap that we have found is the information, access to information. If I'm not on the internet, how do I know where these places are? Who can help me figure it out? So we have some community health workers in the communities now, going door to door. This is where you can find resources. And so if you find patients who need additional resources, please point them to 211. Someone can talk to them on the phone. Someone can help them navigate, because we are trying to ensure that nobody goes hungry in Chicago and that people can have access to fresh fruits and produce in their community, regardless of where they live, and also access to recreational facilities and safe exercise options.
Thank you, Dr. Ethan. There are resources available. Are there any others you want to specifically point out?
I mean, just talking about food insecurity, that ties into the initiative that I work on. The food insecure population has a much higher prevalence in the general population of all the risk factors we've talked about and cardiovascular disease. So what my team and I are trying to build right now is a relationship with various food pantries across the city, and we bring our preventive services to them. So, trying to reduce the barriers of having to go into a hospital system. We come to them and we offer a full prevention screening on site when they're there, waiting for the pantry to open usually. And we check their blood, we check their sugars, their lipids, their blood pressure, and we calculate that cardiovascular risk score. And we have social workers on site and other cardiologists there to plug them into resources they need, and also counsel them on lifestyle modifications and medication compliance and education. So we're in 4 food pantries in Chicago now, and always looking to partner with more people and to get additional funding. Maybe the city of Chicago wants to buy out all my time and support things. But that's but at this point it also just feels like a little bit of a drop in the bucket. There's just a lot of need out there, and I don't know if this panel wants to get into politics, but we're in the end times right now, and it's a kind of a crazy time with food security and Medicaid. So there's a huge need for this, and I know there are a ton of initiatives out there, and I agree with you. I know that there are a lot of people in the city doing different things. It's kind of hard to keep it all straight sometimes.
Yeah, I think I want to move off. We talked about food in the determinants of health, but I do want to kind of go back to as you mentioned, how does a Chicagoan know what they have? And I think, you have to know your scorecard, and that scorecard has to be your blood pressure, your cholesterol, and your blood sugar. And one of the things that we're trying to do, I was fortunate enough to be appointed to the Chicago Park District Board, and what we're trying to do at our parks, if you're only 10 minutes away from a park, you can definitely exercise, but at some of our parks we like to have a place where you can find out your scorecard, where you can maybe get your blood pressure checked, get your cholesterol checked, maybe even get your blood sugar checked. That just gives you a sense of letting you know how you stand, what risk factors you have, and what your risk is for having cardiovascular disease. So that's something that's on the horizon. We're working with CDPH to try and get this going, this initiative. But I think that type of awareness, information, knowing where to go. There's a lot of resources on the internet. I think that's what Chicagoans need to know, that they can know where to go, they can know what to do, how to do better and be more healthy.
Good information. I think we're about coming up on time, but Commissioner Ige, is there any final words for our audience tonight?
Yes, that's something that I've been curious about. So when we look at our data, and our epidemiologist is here, we find out that in the Black community, about more than 70% of people who respond to our survey say they have a primary care physician. We don't have a disparity in terms of primary physician coverage in Chicago, by race and ethnicity. What we have a disparity in is missed appointments. That about 30% of people say that, oh, I didn't go to my appointment. I have a physician, I have a provider, but I didn't go. And I was curious about that, and just wanted to know if you had any thoughts about what can we do to help people stay connected to care. So if we already have people in network, we've looked at the insurance coverage, and we've looked at the trust and satisfaction with care, even where, surprise, there may be something in there that we're missing, but again, the Black community has a higher satisfaction level with their providers than other communities. So there's a lot of assumptions that we are seeing is not really panning out. So I'm wondering, do you know, have you, in your practices and your engagement with your patients, are you seeing that you see a lot of drop-off, and if so, do you have any recommendations for us for how we can help people stay connected to care, annual physical, for instance? Any words of advice there?
That's a $1 million question, right?
I was just curious.
I think it's a lot about reducing.
Yeah,
I think it's pontificating now. I don't have any answers, but I think a lot of it is reducing barriers to getting there and making it happen. So that means flexibility with appointment times. That means possibly virtual appointments, but that also can potentially widen the equity gap if you're only people with smartphones can get a virtual appointment. I think a lot of retention of patients for me in my own practice and what I've done in the community is relationship building, is people taking time. If your doctor doesn't square their shoulders to you and doesn't is typing on the computer while you're talking, doesn't seem interested, there's no real relationship there. There's no mutual commitment. And I think a lot of it comes down to going back to medical education and teaching the doctors that are coming up now to it is on the medical community to be responsible for fixing this death gap, the disparity in outcomes in the population. And that's my biggest interest in this space, is actually inculcating those values in that up and coming generation of doctors. So I don't know if we're going to fix the problem overnight, but I think it's a lot about education and being creative with technology to reduce barriers to getting into appointments.
All right. Any final words or sentences anybody wants to get in? I know we covered a lot of good information, a lot of health information, a lot of lived experiences that people have had with heart attacks and heart disease that have been very helpful. But any final words of advice we want to sneak in before we close?
I think I hit mine. I really think it's important for us to know your numbers. That's the number one thing. You can't hide from it. I think a lot of people, I'm a Black man, so I know we don't talk about it amongst each other. We don't share medical information with each other, which is a problem because we're so bravada and so just so, I guess, arrogant or whatever you want to call it. And we never talk about it amongst each other, but I think we should be able to talk about that. That should be something that should be talked about at the barbershops, at the lounge, or wherever men hang out, at the golf course, basketball court, or wherever we are. They should be talking about their health. Secondly, we should be talking about saying, if you know somebody and say you haven't been to a doctor, or you don't know what your cholesterol number is, or what your blood pressure is, what is wrong with you? How could you not know that? Because you should nowadays. This is not, 75 years ago. This is definitely something that everyone knows is a risk factor. Most people know, and they have to understand it. You just have to accept it, move with it, and say, look, I'm going to know my number. I'm going to know my cholesterol. I'm going to know my blood sugar. I'm going to know my blood pressure. Period. Anything else?
Yeah, I mean, just a parting word of kind of where we started, where 80% of cardiovascular disease is preventable. So we have these tools to calculate risk, identify disease before it ever manifests as a heart attack. So, getting over the bravado or whatever. I mean, I think on the medical community, it's our responsibility to overcome this disenfranchisement and break down the barriers and show up in communities. But on the individual's perspective, it's your life. You've got kids to live for. You've got family members that you have a responsibility to. Get your numbers checked. And we have had unbelievable advances in terms of medications and therapeutics, and we're really good at preventing disease now. I'm sure you're really good at opening up arteries, but I hope to put you out of business. I really do.
That's the objective.
Yeah, but it's about engaging in the system and finding a provider that you really feel comfortable with and have trust in.
I would say just understanding a bigger picture. Definitely respect the heart, but understand that it's other contributing factors like the mouth. The small things, cleaning, taking care of gum disease, that's something small you can do to have a bigger effect on the back end.
Thank you so much.
Thank you, everyone, and for taking the time out. I just want our communities to know that there is a community of support. There are people who care. There are people out there every day who work to save lives and to make sure people are healthy. And sometimes the narrative is that, the healthcare system doesn't care and they're not invested in our communities. And we want people to know that in Chicago, we have good people who care. Kevin came here, shared his story, be vulnerable, and share your stories with other people so people know that we are in this together. This is not just me. There are many other people experiencing the same thing. So we believe that sharing your story, letting others know that you had something and you did something and now you're here and you're doing better. And I think that just encourages people to seek help because they know that there can be light at the end of the tunnel. And we want folks to know that at the Chicago Department of Public Health, we are committed to providing information, helping people navigate, helping people connect to resources that they need. And if what you need is to know your numbers or to find a trusted provider who has your back, we can help you with that too. So if you need help quitting smoking, if you need help with food, if you need help getting a primary care physician, if you need help finding your way around the maze of healthcare system in Chicago, we have folks who can help you with that. So we want to bring you information that will help you stay healthy because we want people to thrive, and we want this life expectancy gap in Chicago to close, and we can do it. So thank you everyone for coming and spending some time with us this evening.
Thank you.
Thank you.
Thanks so much. Good night, Chicago.
Before you all leave, can we get a group shot, please?
Group hug?
Yes.
Group hug.
You go on this end.
Yes, I do that. How about the tall man?
Want to know each other? Thank you.
I think I'm okay. Can we have you go in the back?